Good afternoon, everyone. This is our story from Fort McMurray, and I'm sure it's pretty much the same one you've gone through. As Noreen just said, a little bit of easy and a little bit of peasy, but we got there. So these are our objectives for today: to discuss our pre- and post-QuICR processes at the Northern Lights Hospital, to share information regarding our daughter achievements. So pre-QuICR reflection, these were our feelings. There was a lot of resistance, apprehension, and doubt. I'm sure this sounds familiar to you all. There was process improvement fatigue. Just so many things were happening, so many things had to be improved upon. There was lack of confidence in our ability relating to our staffing resources and to our facility resources. And then here comes our pre-QuICR snapshot. We had no pre-notification from our EMS. All incoming patients were triaged and registered upon arrival. All assessments, including nurse, was completed in a resus room prior to CT. The ED physician contacted the radiologist for CT head, and the radiologist read all the head CT scans and then reported them to the ED physician. In the year 2012, this is still pre-QuICR, we had 8 TPA recipients, and the quickest time we got was 58, bearing in mind that we were going for 60 minutes. In 2013, we had 6 patients, with the quickest time at 52 minutes. 2014, 5 patients, and the closest we got was 56. In 2015, we had 6 patients, and we got 35 minutes, but this was post-October learning session. And then we went on. We started the learning sessions, and they provided us time-saving skills that you've all heard about, keeping the patient on the EM stretcher for the CT scan and the swarming process. And then the QuICR team came to visit our sites, and this was very encouraging. They listened to our problems, and they gave us guidance, and when they left, we could almost feel the change and the mood in our nurses. And a few of them even said that in-service was just a little too short. They could have had some more of that. We started to get physician buy-in a little slowly, but there he is. And then team education was also such an important part. We had to talk to them about the urgency of time and speed and how things are now happening on a concurrent process. This is what the snapshot looks like now in the year, still 2015, the month December. We finally got our 2 TPA administrations post the QuICR in-services, and these were our numbers, a 26 and a 28. And unfortunately, we've only had them. We haven't had any other patients since that were candidates for TPA. And now Natalie will talk about the patients themselves and how it went on the floor.
All right, so I was lucky enough to just start shift with patient number 1. It was a 64-year-old female presented to the department with obvious CVA symptoms. She had an onset of left-sided weakness, facial droop, and slurred speech. Her past medical history was diabetes, hypertension, hyperthyroidism, and breast CA. We received the patch at 1846, so I literally was just coming in the door when a staff member knew I was involved with QuICR and said, "Hey, can you help us with this?" Upon receiving the patch of a positive stroke screen, positive Cincinnati, I advised DI of an incoming hot stroke. And like we said, we do struggle sometimes with our DI department as to whether we do have a tech in-house or not. So first I'll call over to X-ray and just make sure that there is someone there that's able to do a head CT. And if not, I do notify our TCO to go ahead and call the CT tech in. 1854, the patient arrived in the ED, and we did commence a swarm. From that point, I had the resus nurse follow the patient to DI with a stretcher. We left the patient on the EMS stretcher, and they proceeded to CT, accompanied with the primary resus nurse, so that I could stay behind and pre-notify Rapid. At this point, we were able to have a ULI number on the patient, so my communication with Rapid was quick and efficient, and there was no issues there. At 1910, the patient returned to the ED post-CT. IV was inserted, labs were drawn. We had a NIST score of 11. The ER physician made first contact with the neurologist, and by 1918, we were advised to administer TPA. So the bolus was quickly administered. By 2015, we were down to a NIST score of 1. This patient did remarkable. Was admitted to the intensive care unit, was, I believe, in intensive care for a couple days, and then up to medicine for some further rehabilitation. It was pretty amazing to see, and I was blessed to be a part of it. Patient 2, I wasn't involved with this patient, but staff did tell me about their experience with it. This was a more complicated patient who required a little bit more treatment as far as hypertension crisis. So there was a lot of discussion over whether to administer labetalol with the TPA in both arms. I'm not sure if Dr. Jerkal was involved with this one or not. So there was a lot of talk about that. It was a very complicated patient. But in the end, we decided not to administer labetalol in one arm and TPA in the other, but we'll get more into that. So this patient is an 80-year-old male. He is known to our community. He also has a twin in the community. He's got a history of hypertension, previous admissions for hypertensive crisis, dyslipidemia, atrial fib. Recently switched from warfarin to Xarelto. Then he discontinued all his anticoagulants for an unknown reason. So he was found in bed with aphasia and right-sided weakness. So 11:24, this patient, we received the patch of a positive stroke screen. 11:39, the patient arrives in the ED and is swarmed. The IV was already in situ by EMS and was directed to DI again with EMS and our primary resus nurse and our stretcher accompanying the patient. 11:40, pre-notification call to rapid. Again, we had a BP of 203 on 119. 11:51, the patient returned to the ED post-CT. Rapid got another call at 11:53, made aware that the patient had returned to the ED. CT was read in-house by our radiologist and confirmed ischemic stroke. And 11:57, the neurologist called our ED and advised labetalol and then TPA. 12:03, labetalol 20 was given IV push. 12:07, we had a systolic blood pressure of less than 180, so we went ahead and administered the TPA bolus. This patient had an initial NIS of 17. And 12:16, we had a BP of 191 on 114, so we did give a second dose of labetalol. At 12:39, we had a NIS of 15. The flight team arrived, and this patient was transferred out to the U of A. So overall, I feel the team in Fort Mac is very enthusiastic about the QuICR program. We have had challenges along the way, but we're adapting and overcoming. A lot of it has changed with the whole nursing process. We're used to getting that patient into our resus rooms, getting blood work, initiating IV. So it's been a challenge to kind of change the mindset of nursing to let's get this first, treat the ischemic stroke. But we've come a long way. So we're gonna continue doing what we're doing and bring this new knowledge forward to them, and hopefully we can continue to make door-to-needle times less than 30 minutes.